Dr. B here with our series on demystifying the DSM. Today I'm going to be talking about bipolar 1. This is the most severe type of bipolar. Although the DSM, clearly distinguishes bipolar 1, bipolar 2, cyclothymia, I see clinically that this is more like a continuum. Bipolar diagnosis does not necessarily mean severe mental illness, but bipolar 1 severe can be very, very debilitating and actually cause disability. So it's really on this continuum. So when we talk about bipolar 1, this is the classic manic depressive that people think about when they think about bipolar. So this is someone who has clearly had at least one manic episode in their life, a true manic episode, and possibly some additional hypomanic episodes with depressive episodes. So how do we determine the difference there? A true manic episode, clearly, if you're looking at it clinically, it clearly looks abnormal, right? You can even have psychotic features in a true manic episode. Mania one of the first things that I look at when I look at mania is sleep. And so many people have insomnia, and insomnia can be a symptom of depression, anxiety, lots of things. So it's not the diagnostic criteria for bipolar, but often it's not that they're complaining of not being able to sleep. They actually don't need a lot of sleep. They'll sleep for 2 hours and be fine and function. And so that's a true manic episode of having this elated energy that they don't actually need sleep is one of the main things that we see in that. True bipolar 1 is not very common. Less than 1% of the population have true bipolar 1. In the next video, when we talk about bipolar 2, that's a different story, and it's harder to diagnose because you have mania, you have hypomania, and you have depression. And many times people are only seeking treatment during that depressive episode. Manic episodes are often kind of high-risk behavior, things that are out of character. I have had several clients tell me that they become hypersexual during their manic episode. They could, go on shopping sprees. They can do other risk-taking behavior like drinking and driving, things that are out of their character during those manic episodes. And they can identify it afterwards as being completely out of character for them. And so making sure when giving that true bipolar 1 diagnosis, that there is clearly evidence of a true manic episode with the depressive episodes. Unfortunately, bipolar 1 clients are the most likely to complete suicide because the extremes go so quickly, from being on top of the world to literally wanting to die within 24 hours. So it just goes very quickly, unlike someone with depression who the depressed mood, it takes a long time to get to that feeling of suicidality. Bipolar 1 is truly a biochemical problem and likely will need medication indefinitely. So it's important to make sure that we clearly identify those bipolar 1 diagnoses and really looking for the suicidality and protecting them from that piece, and talking very seriously in the beginning about long-term medication compliance. So that's bipolar 1 diagnosis.